Okay, good afternoon, ladies and gentlemen, dear colleagues. It is a great honor and pleasure to participate in this wonderful Neobiotech World Symposium. I'm Dr. Baek from Gyeonggi University in Seoul, which is the capital city of Korea. Let me briefly introduce myself. I trained my prosthodontics in Columbia University in the city of New York. After finishing my residency, I became the diplomat of American Board of Prosthodontics. And I moved back to my dental school and I became a professor in Department of Prosthodontics. Before I forget, I'd like to express my sincere gratitude to your kind invitation and all the support from Neobiotech. Thank you for having me here. Now back to my topic. As a prosthodontist, I'll be covering about understanding CMI fixation for optimal loading. CMI implants were specifically developed for anytime loading, and the concept of CMI fixation was devised for this purpose. So, what is CMI fixation? We've talked about this many times in the morning session. So let me briefly review the concept. So C represents the coronal aspect, coronal fixation of the implants. And M represents the middle fixation of the implant. And I represents the apical fixation of the implants. It's always good to have all these three CMI fixation. In this picture, we can see CM fixation. We got one fixation from the coronal and one fixation from the middle. But because of the sinus, we could not achieve the eye fixation. And in some cases with periapical scar tissues, we also have only coronal and middle fixation. And also, in an anterior implant, if we do have the buccal dehiscence or fenestration, we only can have CM fixation. Also, in sinus area, we only can achieve C fixation, and in a bone where there is a very soft bone, on the middle and apical, we can only achieve the primary stability from the coronal aspect. If we do have the horizontal bone loss, we only can have MI fixation because we do have the horizontal bone loss. And also, in an anterior single implant, if there is a buccal gap between the fixture and the bone, we can only have MI fixation. And this is the least favorable condition that we can get. We can only have eye fixation here from the apical third of the implant. So how can we document this situation? Dr. He from Neobiotech have suggested us very clinically valuable the charting CMI fixation system. How the bone density was in coronal aspect, how the bone density was in the middle aspect, and how the bone density was in the apical aspect. So if we drill, we can find how dense the bone is, how compact the bone is, or how soft the bone is. We can document these numbers with the letters. So C1, M4, I4 means coronal, D1 bone, in middle, D4 bone, and apical, D4 bone. So we can chart this, we can document this, because once we close the flap up, we cannot remember what the bone density was, and we cannot remember what the initial stability was. So not only we have to write the numbers, but also we have to write the initial stability with the numbers and also ISQ value. So primary stability should be maintained, and if it is maintained properly due to minimum bone resorption and CMI fixation, we can go with immediate loading or anytime loading because we can keep and maintain the primary stability. So, how can we succeed in anytime loading or immediate loading before complete biologic osseointegration? in our mouth is very harsh environment with heavy occlusal forces, and this heavy occlusal force will cause micromotion. And from the literature, we all know that micromotion, which is greater than 50 micron, will lead to the failure of osseointegration. So we have to control the forces. We have to consider the prosthetically. We have to do the force control. How do we control the forces? The first is we have to reduce the cusp inclination. And also, we have to reduce the size of occlusal table. This is a good illustration that's showing how we can reduce the cusp inclination. And also, we have to increase the size of the occlusal table, but how many percent do we have to decrease the size of the occlusal table? The literature is saying that narrowing the width of occlusal surface by 30% will reduce the lateral force components. And also, we have to provide some type of wide-centric freedom in occlusal anatomy. Occlusal anatomy should be modified to provide a true horizontal fossa. The occlusal line angles, grooves should be reshaped to contain 1.5 horizontal fossa. This is very important if the patient have immediate side shift of the mandible so that there can be the lateral interferences. So we have to provide some type of occlusal freedom. And the reduction in number of occlusal contacts. So we have to provide the primary occlusal contact within the diameter of the implant. So this the gray part, gray circle, it dictates the diameter of the implant, and our primary occlusal contact should be within the diameter of the implant. And secondary occlusal contact should be within 1 millimeter of the periphery of the implants. So I prefer to provide 2 occlusal contacts, the primary one in the diameter of the implant, and the second one should be 1 millimeter periphery of the implant. This is very important, the crown to implant ratio. As we all know, if we do have the favorable crown to implant ratio, it's very good. However, if the crown gets longer, if the crown gets bigger, we do have external lever arm. If you can see from this diagram, non-axial loading increases as the crown length increases. So long crown can act as the fulcrum, and it creates the bending moment to the crestal part. So the C fixation is very favorable in terms of crown to implant ratio. So the top part will be the crown part, and the bottom part will be the implant part. So the ratio between crown and implant is very favorable. In M fixation cases, we do have okay crown to implant ratio. It's not very ideal, but we do have an okay crown to implant ratio. However, in I fixation cases, we do have very unfavorable crown to implant ratio. So in I fixation cases, we have to limit ourselves not to load the implant. We have to wait at least 3 months, 4 months, or 5 months to achieve biologic C fixation. So first, we didn't have any C fixation here, but if we wait 3 to 4 months, then we do have the fixation from the middle and fixation from the coronal. So in I fixation cases, we have to limit ourselves not to load the implants. We have to provide only aesthetics, not functions. So no lateral forces. It has to be totally out of occlusion until we have the biologic C fixation after 3 to 4 months. I'll show you a case of mine. The bridge work from tooth number 11 to tooth number 13 was failing. And also, the tooth number 21 was failing. This is the sagittal view from CBCT, number 21. Tooth number 21 was failing. This is the actual photograph of the patient. So I thoroughly discussed the treatment plan with the patient, and we decided to do a new bridge work from tooth number 11, 12, 13. And then we decided to extract tooth number 21 and replace it with single implant. At the day of extraction, we placed the implant, and we immediately loaded our implant with nicely contoured provisional crown. 1 day post-op, we redo the bridge work, the provisional bridge, and then we place the implant, and we place our provisional crown at the day of surgery, and this is 1 day post-op. Because we delivered provisional immediately, we could maintain our papilla, and the patient was very happy that he did not use any removable type of prosthesis like flippers that has wires. So after a certain period of healing time, I contoured my soft tissue a little bit so that my pontic base of the provisional and final crown will have some type of ovate pontic shape. And I added some acrylic to have a good symmetry among my anterior teeth. And look at the nicely contoured soft tissue. We do have a good papilla. We do have a good contour of the soft tissue. This is from the occlusive view. We do shape a good contour. And then I used my intraoral scanner to transfer this gingival contour to the fixed final restoration. This is a definitive zirconia work. We did a great job. This is a pre-op, and this is after delivery of the final prosthesis. So in anterior cases, not only we have to make it out of occlusion, we have to decrease the anterior guidance. We have to make the shallow anterior guidance. How do we make the shallow anterior guidance? Number one, we have to decrease the vertical overlap. That means we have to make anterior teeth a little bit short. Not only in the single implant cases, but for the multiple implant cases, like full cases or partial cases, we have to make the shallow anterior guidance by decreasing the vertical overlap. Or we can make the shallow anterior guidance by providing more horizontal overlap here. So how do we make a big horizontal overlap? We can make our anterior teeth a little bit out to labial or a little bit out to buccal. So that will make our anterior guidance more shallow. And also, we have to make a good tight interproximal contact. So if you don't have a good tight interproximal contact, there will be also a micro movement, like clockwise or counterclockwise. So your contact should not be loose. Your contact should be very tight and very good. So I have an interesting issue to share with you. We have to let the patient be on a soft diet. So these foods from Korea, they're really hard, they're really tough. So if the patient eats some food like that, that will cause another failure in implant immediate loading cases. So we have to alter the patient diet by eliminating the hard food about 4 weeks. So these soft diets should be instructed to the patient, and in the literature, the exact wording is pasta and fish are acceptable, whereas hard crust of some bread, raw vegetables, and fruits are contraindicated. So we have to explain to the patient to be on a soft diet. And also in big cases or multiple cases, we have to reinforce our immediately loading provisional with some type of metal framework because it's acrylic, it's PMMA, it's not as strong as zirconia. We have to provide more force, more strength to our provisional prosthesis. So what I do is I just cast the metal framework and I embed it into the provisional prosthesis. If the provisional breaks, then that's gonna cause a big issue. Not only is broken, but also it will cause a lot of stress and micromotion to the fixtures. And when we are cementing the abutment and provisional prosthesis, we should use the permanent cementation like a resin cement. Because if you use a tampon, if the decementation occurs, then that's gonna cause another micromotion to newly placed implants. So instead of using tampon, I recommend you to use a strong cement. And these, my recommendations are not from my own experience. It's not empirical, but it is supported by the literature. This is a good article by Dr. Goh, published 2012. And in this literature, it's also saying to provide narrow occlusal platform, and occlusal contact should be inside the implant diameter. And the provisional prosthesis should have flat cusps, and the patient should modify their diets by avoiding hard food. And also, not only intercuspal position, but also we have to provide groove function occlusal scheme. Because if the canine is included in the provisional, like big unit, we provide canine guidance, then that canine will have to suffer from all lateral forces. So we have to decrease the lateral guidance angle to develop a groove function situation. And for anterior provisionals, we have to distribute all protrusive contacts evenly to all of our anterior teeth. So which fixation is better for anytime loading? Absolutely, we have to have C fixation here. CMI fixation is always good for anytime loading. But here in eye fixation cases, we do have a big crown to implant ratio. So this is unfavorable. And if you do have the lateral forces, it's gonna be very detrimental to the fixture. Also in MI fixation, it's very detrimental. And this anterior MI fixation is also gonna be very dangerous. So we have to be very careful. So fixation for loading, most stress is concentrated in the crestal area of the implants. So implant loading protocol is based on the insertion torque. The insertion torque, which is greater than 30 Newton centimeter, 30 to 40 Newton centimeter, we go with anytime loading and immediate loading. However, if the initial stability is less than 20 Newton centimeter, we have to submerge the implant. We have to let the implant sleep for 3 to 4 months. The most important thing here is do not exceed 40 Newton centimeters. Because C fixation is very crucial, but we are in a dilemma that to achieve the strong C fixation, we may overcompress the bone loss. We may overcompress the bone, and that's gonna cause the bone loss. So make sure do not exceed 40 Newton centimeters. So to summarize my presentation, these 5 are very critical in anytime loading. Ideal implant position. And what I mean by ideal implant position is tilted implants like this will cause the cantilevers and create non-axial occlusal loading. So we have to place as vertical to our occlusal plane. Increase implant surface area. The most appropriate implants have been developed for anytime loading by Neobiotech. The CMI IS2 is very good. CMI IS3 is also very good for anytime loading. Avoid cantilevers. Not only it breaks from the function, but also if it breaks, it's gonna cause a lot of stress to our distal implant. Shallow anterior guidance, I already talked to you about the shallow anterior guidance by decreasing the vertical overlap or by increasing the horizontal overlap. And we have to provide some type of night guard or occlusal guard to the patient, because if the patient has some parafunctional habits, in night we have to provide some type of occlusal guard to protect our implants. So we have to come up with the idea of implant protected occlusion. We have to protect our newly placed implants by utilizing these concepts that I already told you. So we have to, most common complication with anytime loading prosthesis are related to my biomechanical overload. And it's paramount that the concept of implant protected occlusion should be integrated in reducing force factors. Controlling and maintaining the forces and occlusion is at its foremost importance. So my recommendation today was just a generalized recommendation. The specific occlusal considerations should be modified appropriately in the individual patient. So the guideline, we have to, stability dip can be eliminated, atraumatic drilling and implant placement is the key factor, and maximum bone to implant contact should be established. Lastly, 10 clinical tips to achieve anytime loading, to succeed in anytime loading. In D1 or D2 bone, which is very hard, we have to obtain 40 Newton centimeters passively by pre-tapping. And in D3 or D4 bone, we have to obtain 30 to 40 Newton centimeter by actively placing our implants with self-compaction. And do loading if there's no dip and ISQ value maintains higher than 70 for 3 to 4 weeks. Number 6, splint all the implants. And number 7, at least place 4.5 millimeter or wider implant in posterior area. And splint your provisional with more than 3 implants. And it's always good to fabricate screw-type provisional prosthesis. So, thank you for your kind attention. And now I'd like to toss the microphone to Dr. Red McGanney for successful aesthetic anytime loading.